Welcome back to the King's Podcast, the Wellness Dive with Lucky. I'm your host, Esther Lackie. 2 episodes ago, we were joined by Dr. Said from Pulmonology, where we took a deep dive into lung cancer in general. Today, we are joined by Dr. James Douglas Aitchison, consultant cardiothoracic surgeon here at King's. Dr. James, or would you prefer Dr. Aitchison or Aitchison?
James is fine, or Doug.
Okay.
Pleased to meet
Thank you so much for joining here today.
You're welcome.
And today we are discussing about lung cancer screening.
Yes, that's right.
What is lung cancer screening?
Lung cancer is a disease that starts from the lung, and as a lot of people know, it's associated with smoking, but not everybody who has lung cancer has smoked. We know from the United Kingdom that over 25 to 35,000 people a year die from lung cancer every year. And more people are diagnosed from lung cancer than breast cancer or bowel cancer or bladder cancer.
So is lung cancer the leading cause of cancer deaths?
It is, yes.
Yeah. Statistics worldwide, would you happen to know about them?
America and a lot of the Western world are similar. In the UAE, the numbers are smaller. There were 151 recorded lung cancer cases in 2019, which is the last full set of records because of the corona epidemic. But the UAE has a much younger population, and I think we'll see the numbers start to rise as the population starts to get older.
So you're trying to say that lung cancer is not a disease of the young, it's a disease of the...
Generally, it's a disease of the older, but it is possible for people to get it even at a young age. The youngest person I've operated on with lung cancer was 17.
Wow. So what are the risk factors?
Okay. So the risk factors for lung cancer are primarily smoking or exposure to smoke or radioactive gases from other places, but smoking or other forms of smoke are by far the most commonest cause. Some are inherited.
So for instance, your patient was 17 years old. What was the cause?
We didn't find anything else, but that was in a time when genetic screening and gene analysis wasn't routinely undertaken. So maybe if we were to put the clock back 10 years and have a look, maybe we would find something different then.
So you mentioned smoking as the key cause.
Yes, that's right.
How many years do I actually have to smoke before I can catch lung cancer?
Every cigarette causes a degree of damage to your lungs. Some of that damage is not related to cancer, it just damages the functioning of the lungs and can cause other diseases like emphysema or bronchitis. Every cigarette will cause some damage to some DNA in the cells, and when there's sufficient damage to the cells, then it is possible that they will turn malignant and become cancerous and then start to grow. But that is probably a slow process. You're looking at between 4 to 6 gene defects being accumulated in the cells before they turn to cancer in general terms. We know that for patients who've been smoking for 20 years, their risk of cancer is sufficient that if they're beyond the age of 45 to 50, it's recommended they have CT scans for screening.
So other than this particular group of people, who else should be screened?
Anybody who's got a family history of lung cancer and is themselves a smoker would probably be worth considering having screening, even if they've not been smoking for 20 years. Certainly, if they have symptoms of anything worrying, then they should also consider seeing their doctor.
Right. I'm a smoker. Okay. I'm a smoker. I'm just giving you an example.
Yes. Okay. Good. Yeah.
So, at what point should I come for the screening? And when I come to see you for the screening, what should I expect?
Screening is looking at people who are well to try to find disease that's hidden. We know from the UK lung cancer screening program, about 6% of those patients who'd smoked for 20 years and were aged 50 or over had lung cancer that they didn't know about. But if it's caught early, when it's small, it's not advanced and it's potentially curable. But unfortunately, in the United Kingdom, about 40% of people who have lung cancer present to the emergency department with symptoms that need them to stay in hospital. By that time, the cancer is so late that the only thing can be done is keeping the patient comfortable and maybe prolong life with chemotherapy for a few months. The aim would be to get people who are well or people who have the first signs of symptoms to come to hospital to get treatment early. And if it's caught early, then it's potentially curable. And that's the vital thing to say. So if a patient has symptoms of a cough that hasn't gone away after more than 3 weeks, or is coughing up blood, or chest pain that's unexplained and hasn't been diagnosed but is persisting, or shortness of breath, they should certainly think about seeing their family doctor for investigations to be done.
Let's talk about screening and the results of screening. What are the stages of this cancer?
Okay, so screening would be aiming to pick up those patients who have a very small cancer. The screening would be these days a CT scan of the chest. It's a low radiation dose, so one at middle age wouldn't need to be worried about the dose of radiation from that. And it would aim to pick up tumours or growths within the lung that are smaller than a centimetre.
So there's stage 1, stage 2, stage 3.
Yeah. So stage 1 is where the tumour is small. Stage 2 is where it's beyond a certain size, which is beyond 3 centimetres and up to 5 centimetres, or has affected the lymph glands within the lung. If it's beyond 5 centimetres or has spread beyond the lymph glands in the lung to the lymph glands outside the lung within the chest, then that's stage 3. And if the cancer has spread outside the chest around the body in a process called metastasis, then that's stage 4.
So, Doc, I've been screened and I have one of the cancer stages, and it gets to the treatment bit. And you're the doctor for it, or one of the doctors for it.
Yeah.
As a cardiothoracic surgeon, are you a cardiac surgeon or a thoracic surgeon? Okay,
I'm qualified in both. And throughout my career, I've done both of them. But here we're talking about the thoracic surgery, which is the bit in the chest, excluding the heart, which is the cardiac part. So if the patient has lung cancer and it's stage 1 or stage 2, it's likely that we can be considering curable treatment. And it's likely that that will involve surgery as long as the patient is happy to have surgery and is strong enough and fit enough to have surgery. There may be in stage 2 a requirement for consideration of chemotherapy or immunotherapy as well to try to mop up any cells that might have escaped around the body and formed metastases that are not known about. Yeah. So stage 3, where the cancer has spread into the lymph glands within the chest, then most patients are treated with chemotherapy and radiotherapy or possibly immunotherapy. It is possible, if there's a good response with that, to consider adding surgery in as well. And for some people, that may be important. But the standard treatment for stage 3 is chemotherapy and radiotherapy. For stage 4 tumours, then the question is which parts of the body are affected? Is it the liver or the brain? And which medicines help out for the metastases to those sites?
There's surgery, there's chemotherapy, immunotherapy, and any other therapies.
And radiotherapy, yes.
There are times when all these are combined.
Yes, that's right.
At what stage would that be?
Well, patients probably won't get everything all together all at once, fortunately, because I think that might be too much for a lot of people. But if the patient presents with stage 1, they may just need surgery, and hopefully that will be all they need, because the survival is up to 80% potential cure with surgery for lung cancer. If it's stage 2, we would chuck in the chemotherapy as well, from a point of view of aiming to maximize the survival at 5 years. For the more advanced treatments, or if cancer were to recur after surgery, then the other treatments added in.
All right. So, doctor, I'm going to ask you this. How has management of lung cancer or screening for lung cancer changed since COVID?
One of the problems has been that doctors have not seen the patients since coronavirus. And quite rightly, a lot of the patients have wanted to stay away from hospitals if they were relatively well. They didn't want to pick up illnesses and things. But now we need to encourage people back. So the data from the UK has shown a significant increase in late presentation with lung cancer. And I think we need to reverse that by encouraging people with symptoms to come and see their family doctor for investigation, and for people who are well to promote screening.
Since you're talking about lung cancer screening, that's the main subject, I have to ask, are there any risks involved in lung cancer screening?
So the tests that are done are simple, and most of them have little, if no, risk at all. So spirometry, blowing into a box to measure the volumes of air breathed in and breathed out, has no risk at all. An ECG or heart tracing will pick up any major abnormalities with the electricity of the heart, and again has no risk at all. The low-dose CT scan does have some radiation with it, but that amount of radiation is very small. It's less than you would receive on an airplane flight from here to America and flying back. And nobody would complain about radiation exposure about going on a trip to the USA.
Definitely not. All right, Doc. There's something known as a false positive. What is that?
So that's when something comes up as a finding on the CT scan that turns out not to be cancer, a nodule from something else, such as previous infection or previous injury, something like that. And the way the screening works, it's not just looking at one X-ray, it's also looking at what happens to the very small things that are found that could be an asymptomatic false positive. So if the patient has, say, a 6mm nodule that's picked up, the advice would be that rather than remove it, they have another scan at a short interval, maybe 3 months, maybe 6 months, depending on other factors. And if it doesn't move or change or grow, then the answer is it isn't anything to worry about. It can be kept under surveillance. But obviously, if they see something that's 2 or 3 centimeters, that's spiky around the edges and looks more typically like a cancer, then there wouldn't be a plan for a follow-up. There would be a plan to diagnose it, take a biopsy, and if it turns out to be cancer, to remove it.
Okay, so you mentioned that certain individuals are at risk of lung cancer.
Yeah.
So this set of individuals, are there factors that could allow them not to be screened for lung cancer?
I think it's difficult when people have a positive family history to say that we can exclude them from something. I think what it means is the reverse, really, that we have to keep a closer eye on them and that they need to report any symptoms and things that they have earlier. So certainly somebody with a family history of lung cancer, particularly if it was at a young age, and that they're a smoker, then we would maybe get a CT scan for screening at 40 or 45 rather than wait until 50. But at the same time, if their grandfather had died of lung cancer at the age of 98, I probably wouldn't be getting a CT scan on a non-smoking 40-year-old. The answer is that it's very unlikely that they're going to get lung cancer at this age, and very unlikely that a scan is going to be of any benefit at all.
So, for instance, can an individual who's about 81 years old be screened for?
Yes, absolutely.
It's recommended.
Yes, because we know that the risks of cancer increase with age, and a fit and healthy 80-year-old in the UK would live on average at least 7 years. So if they're fit and healthy and have no trouble, there's no reason not to have screening, and there's no reason not to treat it. The oldest person that I've done a lung cancer resection on is 92. And I certainly know that 4 years after his surgery, he's doing nicely. So there's no barrier to age as such. It's just a question of, are they strong enough and healthy enough to have the appropriate treatment?
Well, Dr. James, thank you so much for joining us today. I look forward to seeing you again here in the podcast room. Otherwise, I'm just going to continue bumping into you at Starbucks.
Great.
To know more about the cancer screening program at King's, call 800-7777 for more information. Until next time, bye-bye.